did share a little bit about herself already, but did just want to recap that her and her team over at UCSF, Center for Excellence in Primary Care, have been doing a lot of really great work in the GME space, especially as it relates to their primary care teaching clinic model. They have a series of really great resources that she's going to share a little bit about with you today. But we'll make sure to, redirect you all to their website where you can find some of that additional information. They've been really great partners to CPCA in many different ways. This is just another example of how we work together to spread the knowledge that we have for you all. So thank you, Dr. Khan, for joining us.
Thank you. Thank you for having us. Really excited to join you all here today. And so, like Natalie mentioned, what I'll mostly be talking about today is the primary care teaching clinic. And so really honing down on that experience of the clinical training for residents. And to sort of summarize a little bit of how we got into this work, we like to use this quote, which is from a faculty preceptor that we talked to early on in the process of doing this work. And so what they said was, when I started in the clinic, there was chaos. There were too many patients and we couldn't take good care of them. And the residents always had someone sicker in the hospital they needed to go back to, and clinic was leftovers. So we felt like this actually captured really well on the sentiment that is very common in a teaching clinic, both from places that we've worked with as well as personal experience, and in terms of that sense of the chaos there, and the sense that there was nothing, things could never really work well because there were so many moving parts. And so really what we're talking about is this dilemma of teaching clinics having really, because of the way that residents are trained and that have to be in many different settings, they're really often only in the clinic 1 or 2 half days a week. That's often true for many faculty members as well. And this really leads to challenges for the clinic to do what it needs to do for patients. So having good continuity of care for patients, having patients see the same providers over time, having good access, so patients being able to get appointments when they need it, as well as having a robust team-based care. And so having teams that work together and function well over time. All of these have ultimate challenges when it comes to trying to make this work when there are X number of residents coming in and out of the clinic. And so we talk about this idea of the double helix, which is the double mission that teaching clinics have. So there's the mission of providing good clinical care and high quality to patients, and then there's also the other mission of teaching and providing good training and education. And a lot of these times, these two missions seem to be at odds. So our question was, how can these actually come together, like the strands of a double helix, and actually work well together and actually be synergistic instead of always in opposition? So what we did is, over the past several years, we took on a series of site visits. So at this point, we've been to about 45 different primary care teaching clinics, spread out all across the country. So a mixture of, it's about 2/3 family medicine, 1/3 internal medicine, and a couple of pediatric residencies, and really spending time, a few days at each of those training sites, interviewing, shadowing, seeing what's going on the ground. And our initial idea here was really try to figure out how are different places addressing all of these challenges that all of these teaching clinics have to deal with. What are some best practices that we can pull from that, and how can we spread that? So we started this with a grant with the Macy Foundation, and we published our findings in this report, which is available online with the AAMC's website. It's very long, but it's also we also put a lot of case studies in there that kind of highlight some of the things that we observed at these practices. So it's a helpful thing to be able to flip through and kind of see what different places are doing. And so the framework that we used to do this study is something that we've been calling the 10 building blocks of high-performing primary care. Have any folks seen this graphic or have heard of this before? Okay, awesome. And so this is actually based on previous work that our center had done on non-teaching clinics, so regular primary care practices, finding out what are the components that make a practice high functioning when it comes to delivering great primary care. And so we had built this framework, and there's a lot of components up there that are very similar to models you might see from patient-centered medical home models, for example, continuity and access. And what I think makes this different is that there's an order to the madness. And so you see that there's numbers from 1 through 10, and there's levels of these things. And the point of that is that there's actually is a rough order to what components you need to have a good foundation in before you can really make progress on the higher level blocks. So for example, you really can't do any population management if your practice does not have empanelment or if the empanelment is incorrect. And so the work in any of the blocks is never really done. It's always an ongoing maintenance process, but a strong foundation in the bottom 4 building blocks are really crucial to be able to make meaningful change in the upper blocks. And so it can be a very useful framework both for understanding what's going on in a practice as well as what needs to happen to improve next. So after we did the study with teaching practices, we realized there's a couple of components missing from here. So we actually had to add 3 blocks. And so when we come to talk about teaching clinics, we're talking about the 10+3 building blocks of high-performing primary care. And so the first one we added was resident scheduling. So this is huge, and we'll talk about this a little bit more, but for folks who have had experience with residents, we know that this is pretty much affects everything else in the practice when it comes to how things work. The second one we added is called resident engagement. And so this, we mean how are residents engaged in the practice? Are they kind of seen as just past guests that pass through the clinic every 3 years and don't really have an integral part in delivering and improving care in the clinic? Or are they actually really engaged as co-leaders in the clinic and have meaningful involvement in improvement projects and feel like true members of the clinic? And then the last one we call resident work life. And so we just differentiate this from the idea of work-life balance and burnout, which is out there, and it's related, but what we really mean by this is what is the experience that residents are having in the clinic? Are they seeing high-functioning primary care as a doable job that they can go on and have careers in? Or are they seeing the chaos and seeing burned out preceptors and seeing that this is not a doable thing for the future? And so these things, these are the 3 additional blocks that we have, and there's sort of cross links between all of these blocks. But what I'll be talking about in terms of how to tie these all together is the idea of clinic first, which how many folks have heard of this before? Great. And so I'm going to call on you. So what have you heard?
Well, it's just like different approaches, like if you could schedule, or it's just a focus on the primary care continuity clinic is sort of the main focus of the educational experience, and the things should sort of revolve around it.
Great, great. That is fantastic. Explanation of what we mean by clinic first. And so how this term first came around is it was initially coined by the Valley Family Medicine program in Renton, Washington, and they used it to mean a set of curriculum changes to really, again, prioritize continuity in the clinic and experience in the clinic for their residents. And then this idea kind of spread in the regional medical education program of WAMI, so in the Northwest. And then we pretty much co-opted it to signify this philosophy of prioritizing the primary care clinic in residency training. And that in order to do this, creating high-performing teaching clinics is really essential. And so there's this, we think about these things a lot of times in spectrum. So there's on one end of the spectrum, you have kind of the very traditional academic way of looking at training, which is very hospital first, and then clinic is leftovers. Clinic is very much sort of an afterthought when it comes to scheduling, when it comes to the educational priorities, et cetera. And on the other end of the spectrum, we're talking about clinic first. So this is not necessarily to say that hospital has to be second, because again, the hospital is an important place for training and education. But what we're saying is traditionally the academic paradigm has been the majority of medical education and the value of it comes from an inpatient setting, when we actually know that a majority of care happens in the outpatient setting. And so the idea of clinic first is really about bringing up the clinic in the world of residency training to recognize that it is important, and that if we want our residents trained well, we actually have to invest appropriately into the clinic and make it a high-performing setting. So we summarize a set of clinic-first action steps, and so we'll be going through these one by one, but to summarize, as mentioned, 2 of these things are very specifically related to scheduling, and so that we've noticed that in these high-performing practices, there have to be, for example, consistent resident schedules that really prioritize continuity and eliminate that tension as much as possible between the inpatient and outpatient settings. There needs to be a small core of clinic faculty. The overall clinic has to be operationally excellent, and I'll speak a little bit more about what we mean by that. We want cohesive and stable clinic teams. We want to increase the overall resident clinic time to enhance learning and access, and we want to engage our residents as co-leaders of transformation in the clinic. So we'll be going into more specifics for each of these sections. So the first one I'll start with is resident scheduling, which I think anyone who's ever had a part in resident scheduling this is a favorite thing to do. So again, this concept that we really want these schedules need to be consistent and to have priorities that benefit the clinic for continuity for patients. And so what does that mean logistically? So the residents need to be scheduled in the clinic very regularly, very predictably, and very far in advance. And this is really necessary for those schedules to be able to line up so you can have the team in the clinic be able to work together with the same people over time. There should be short intervals between significant periods of clinic time. So for example, if residents are here in clinic a couple of times this week, but they're going to be gone for the next 3 months, this is extremely difficult for continuity for patients. And then we want minimal outpatient-inpatient tension, and so we'll speak a little bit more about that. And so the other clinic first principle that ties into this is just increasing overall clinic time. So looking at the overall residency program and seeing how much time are residents actually spending in the clinic versus other things. And so just for reference, the average number of half days in clinic during training for 9 of the family medicine clinics we visited was 350 half days. But there was a huge range. So there was a range from 250 up to 550 for one of the places that we visited. So there's actually a huge variability out there in terms of what programs are doing in terms of the resident presence in the clinic. All right, so in terms of talking about scheduling, what are some of the things that need to be paid attention to in order to get that consistency and the regular scheduling? And so we'll be using a series of case examples from some of the bright spots that we like to highlight from our visits. And so this first one is from Tufts Cambridge Health Alliance Family Medicine in Boston. And so their practice manager works extremely closely with the residency manager on a daily basis. They're talking to each other all the time. And this is really necessary because all the changes that come with resident schedules, sometimes there's a lot of variability that can come from that. And so these two people basically are best friends. And they have basically a set of very specific scheduling rules that they follow very strictly. There's a 6-page scheduling template, for example. There's a 13-page scheduling Bible of rules. And all this is all to make sure that as much as possible, the clinic schedules and the resident schedules and when the residents are going to be in clinic is very little, as little as possible is left up to chance. And this needs to happen in order for the clinic not to be totally chaotic when it comes to not even knowing who's going to be there on a particular day. And so their yearly schedules for the residents has each half day specified in detail on every location when those residents will be in clinic. And they've set up these templates so that they have pretty much roughly the same amount of residents and providers in clinic for every half day. And again, you can imagine that the downstream effect of this is that it really cuts down on the chaos that comes from having too many providers for too little rooms on one day and then the opposite on another day and not enough staffing, et cetera. And so the other thing that schedulers really look at is preserving the medical assistant to clinician pairings. And so we'll talk a little bit more about this when we talk about team-based care. And then lastly, in terms of thinking again about the priority of the clinic, scheduled patients for the clinic are only canceled in extreme emergencies. And so this is in opposition to what you might see in a lot of traditional clinics where, let's say on an inpatient rotation, someone is out sick, they pull the resident from clinic because we need someone to cover the inpatient service, so that's just what's going to happen. And so they really have built things in to avoid this. So there are programs that do a Jeopardy resident and things like that. But again, the underlying philosophy there being that it's not okay to just pull residents from clinic and cancel all the patients to cover other services because the clinic is also extremely valuable and important place both for patient care and for training. So I'm going to talk a little bit about some programs that have actually gone to a little bit more of a wider, broader scope change in their schedules and moving away from the traditional, what we think of as the 4-week block model in terms of overall resident schedules and how they've been using these different models to achieve some of these goals for clinic first. And so University of Oklahoma at Tulsa is one example of several programs that are now moving to what we call a 2+2 mini block model. So instead of having 4 weeks on one rotation, 4 weeks on another rotation, they've kind of split it to two-week spurts of each experience. So for example, 2 weeks on gyne, 2 weeks on inpatient, but alternating with 2 weeks of outpatient heavy blocks. And what their outpatient heavy blocks is, I don't know if you can see, but it's very heavy in their continuity clinic. So those residents there's several sessions that week. So basically, they don't go longer than 2 weeks at a time without having a significant presence in their clinic. And within 6 months of starting this new schedule, they've increased their continuity in their residency clinic from a range of 27 to 40% to 50 to 58% in the first 6 months. And they're continuing to study this and pull those numbers. They also found that this really increased their resident satisfaction in the learning environment. So when we talk about resident engagement and resident work life, they felt that this actually made a huge difference because at least for 2 weeks at a time, the residents felt like the clinic was actually their home, as opposed to the hospital being their home, and the clinic was just somewhere they were farmed out from a couple of times in the month. So this other example we have, it also looks very non-traditional. It's from Kaiser Washington in Seattle, formerly known as the Group Health Program in Family Medicine. And they do a longitudinally integrated model. Has anyone ever heard of sort of what they do, what it looks like? So they've kind of done away completely with the idea of blocks, and they've integrated all of their residency experience to be continuous throughout the 3 years. And what that looks like, for example, is that they have 1 to 2 week inpatient bursts, usually more on the 1 week side. Their OB shifts are done in 3 to 4 days instead of rotations. And the residents are doing each of these things much more frequently than when they were on a block rotation. And what this allows them to do is that they're actually in clinic for at least 3 to 4 half days a week, and they're never really gone from the clinic for more than 7 days at a time. And so what this allowed them to do is really have their residents care for panels of 400 patients from day 1 of residency. So the typical thing you usually see is residents might start with 10 patients or something on their panel because they're in clinic so infrequently their first year, and then they have to slowly grow those over 3 years. And so here the idea was we want our residents to really be able to practice as a true primary care provider. We want them to know what that's like, feel that ownership. And so from the very first day, they're going to be taking care of their full panel. And what they had to do is kind of flip that traditional idea of interns being in clinic very little and then third years being in clinic a lot. They kind of had to flip it because the interns see very few patients in a half day. So their interns are actually in clinic a lot more often in their 3 years because they have to be able to see more patients to be able to manage this panel. Okay, and they overall increased their clinic time by 30% of their total training time, and they were able to increase their patient continuity with this as well. So I want to talk a little bit about minimizing the inpatient-outpatient tension and what that means. And so this quote is from a resident at Cincinnati Internal Medicine, where they do something called a long block. So for basically the beginning of second year to a little bit into their third year, though that whole experience is ambulatory. So their residents are just basically completely immersed in the outpatient world for the entire year and change. And so what this resident said about it was, it's very difficult to focus on outpatient care when on the wards. Long block was a reprieve, and it was really nice to focus on outpatient. I felt like I could be a real primary care doctor and prepare for the real world. So I thought this was a really good illustration of that tension that residents and faculty feel when sort of running from an inpatient to outpatient setting, usually within the same day in a traditional training program. And the idea of, is that really conducive to learning? And so, there are many folks that have the argument that, that's what they're going to do as an attending, and especially in more rural settings where they need to be health covering multiple things in the same day, then they should be training that way. And then other folks have come around to this idea that maybe for when you're in the learning and the formative years of your training, that you don't need to do that. That's a lot easier to do the switch once you've actually gotten those skills. And in the meantime, your ability to engage and immerse yourself in the setting that you are, actually it makes a big difference to be able to focus on one place at a time. And so it doesn't necessarily mean that this model requires being in the clinic only for a year at a time. And so what many programs have been doing, including the University of Washington Internal Medicine, is that they're keeping their sort of 4-week typical block scheduling, but they have rearranged it so that the residents have primary care clinic for a full day. So instead of doing this half-day thing where they're on rounds in the hospital in the morning and then trying to wrap up and run to clinic in the afternoon and focus on that and getting paged about orders and things, they know which day of the week they're going to be in the clinic instead of in the hospital, and the teams are arranged to be able to have coverage to not avoid this whole midday transition. And so they've written an article about this as well, and there's been also studies that found that in terms of resident satisfaction and engagement with the learning, that this actually has some benefits to that. So that was a lot about scheduling, which is, we do a 2-hour workshop on this in our sort of longer training, and we can go on forever, but we want to get to the other parts of the clinic first components too. And so this next piece I'm going to talk about.
Actually, just a quick question.
Sure.
That quote that you showed, I think it really speaks to what I'm thinking is, why are you spending all this time training in the hospital when in the real world you're going to be doing primary care?
Mm-hmm.
And I know that's like a very skewed statement I just made, but that's kind of the elephant in the room. So are there programs that are basically saying, we're not going to train you inputs so heavily into patient medicine. We're not going to send you to the ICU for a month, and we are going to focus on primary care. We're going to train you in other programs out there that are bucking the status quo.
Yeah, definitely. So that is something that's also been exciting about the clinic first movement is that programs that do identify with the fact that they do want their trainees to be practicing great primary care, be great ambulatory doctors, it's been a great way for them to sort of like rally support around that idea. And then I like to refer back to that idea of the spectrum, right? And so for some programs, then yes, definitely like trying to become trained excellent primary care providers is definitely a part of the mission. And we're kind of a little bit preaching to the choir given that we're at the CPCA right now. And I'm definitely very passionate about that for sure. But even if in programs that don't necessarily have that in their mission, let's say they are in a shortage area where they're going to need more hospitalists in addition to that, but we still like the idea of the spectrum in the sense that still, if you want to be a good doctor in general, like being able to manage patients in continuity clinic is actually also a really important part of your training. And there's also value to that in addition to just the hospital. So again, like what you're saying is that our training setting does not match up necessarily with where the majority of healthcare needs to happen in real life.
If I could just jump in there, you still have to meet the ACGME requirements. And the ACGME still requires ICU, as an example, right?
Yes.
And I don't want to take, it is the issue, and ACGME tends to run, what, a few decades, you think, behind? So, don't report, don't let me hear that, take that from the recording. But, so you still have to meet the requirements. And I'd be curious as to your opinion on this, Marianne, because it's right, my opinion is right now it's not an easy go of it to start a program de novo with something that ACGME sees as innovative. The easiest go is to do completely traditional block rotation schedules, 1.5 day a week in clinic. You know, that it's the easiest go. You're going to get a lot more questions at this stage. I mean, and I'd be curious about your opinion, but I mean, I've had some where we've done it.
Yeah.
And it's harder. I mean, I did a longitudinal rural training track in Washington, and it took that program director a lot of explaining.
Right. Yeah. So we actually have worked with some programs that have built in on the outset their intention that this is going to be a type of program that really emphasizes the clinic experience.
Right.
And so we've actually had experience with programs that are doing that. And I would say sometimes the barriers are not necessarily where you expect them to be. So for like the programs that are kind of moving to this 2+2 model, so they're existing programs, but they're changing their schedule, they actually did not find that much resistance from ACGME and the RRC, and where they actually ended up coming into conflict was with the American Board of Family Medicine, who said that actually, you know, even though the ACGME doesn't mind you violating this rule that you have to spend 40 weeks in the continuity clinic, and this stuff technically doesn't meet that by like a few weeks. So it's I think I could go more into that if people are interested later. But I think sometimes it's a matter of you can have a philosophy definitely ingrained into what the program's going to be, and then you have to have an eye out for what the requirements are. And so the program directors who have done the 2+2 changeover, they've really just taken a seat and looked at everything and calculated all these numbers, looked for innovative ways to do the counting to meet those requirements. And sometimes they've made a conscious decision to say we're actually a pretty inpatient heavy program. I think we're going to make this conscious decision to shift some of that time to outpatient because we right now believe that is what our trainees need. So definitely an exercise and values clarification for the program. All right, so I'm going to click ahead a little bit and so speak really briefly about having a small core clinic faculty. And so many of the sites that were high functioning that we visited have many faculty attendings in the clinic for at least half of their FTE. And so this in contrast with some clinics that are based in tertiary academic medical centers, for example, where a lot of you can have 20 to 40 faculty that are only in the clinic 1.5 day a week, and there's really no consistent faculty leadership presence there. And we bring this up because having some small core clinic faculty, even if not all the faculty involved in the clinic are there, but at least we have some that are there more than half the time, and that's really the home for their careers. It's really important for engagement and leadership in the clinic. It's important for resident teaching. It helps provide continuity for patients and teams, and it helps the teams become more stable. So to segue into teams, so talking about building cohesive and stable clinic teams, with a lot of the issues coming up in teaching practices being how do you pair consistently residents with medical assistants when residents are still part-time? How do you create teams that are the same size every day when the scheduling leads to maybe 6 residents in clinic one day and 0 another day? And how do we make our teams feel small enough so that patients feel comfortable? And so, first thing I'll talk about is the idea of a teamlet. So traditionally what we see in a teaching clinic is that you have some number of MAs in the clinic, some number of residents. When they're seeing a patient and coming out between patients to say what this patient needs, they're basically just running around and looking for whoever's available. So those lines are sort of like arrows of communication there. So that's a traditional setting. And what we call the teamlet model is there's actually a paired system between MAs and residents so that you're working consistently with one person throughout the clinic session, and that MA is working with your panel of patients for that morning. And that doesn't necessarily mean that you need the same number of MAs as you have residents, because again, residents are very part-time in the clinic. So one MA might work consistently with the same resident, several residents over time, but each time one of those residents is in clinic, if it's a stable teamlet, they're working with the same person. And so again, this also comes up on the spectrum. We like our rainbow spectrum. And so again, one end of the spectrum being clinicians looking for any available medical assistant. In the middle, you have maybe each day MAs are paired, but from day to day it might be different. And on the far end of the spectrum, you have clinicians who are working with the same MA each day in stable teamlets for the first time. And that really gets to a lot of benefits in terms of figuring out ways to improve the workflows on the team, figuring out how things even work in the clinic and what needs to happen better, and makes a very big difference in terms of both functioning for patients as well as experience for the clinician and the team and the MAs. And so some examples we have of stable teamlets. One example we have is from Greater Lawrence Family Medicine, which is in Massachusetts. And so they have 3 residents paired to 1 medical assistant per mini team. That's how they've set it up. And their team members are rarely shifted away from their home team. So that's really important when you're scheduling, so always try to consistently have the same people working on the same teams. And so their MAs are working with several clinicians, but again, residents and faculty are working with the same medical assistant pretty much 80% of the time. And this relationship builds so much over the 3 years is that by the time they graduate, so part of now a tradition and part of their graduation ceremony is actually for the residents to honor the MA that they've worked with for 3 years because they've learned so much from them and they've developed such a great partnership. So another example is from the Trinidad Family Medicine Residency, and they actually transitioned to this. So they didn't start off like, they haven't been doing this for a long time, but they've set it up with 4 residents and 2 medical assistants per team, with residents working with one of their 2 MAs 80 to 90% of the time. And so they've set up in their schedule that priority for the team pairings goes to the R3s, and then trickles to the R2s, and then to the R1s. Again, having some sort of system in place to really maintain this was a goal that they set out to do. And again, so bringing up just to piggyback on the idea, scheduling here is fundamental, and that priority needs to happen for that scheduling to be successful, and that for that to start to happen, the resident schedules need to be really fixed and predictable, because if they're getting pulled for another rotation 2 weeks before, then you really can't make the rest of this happen. Okay, I'll speak a bit about co-location, and so again, traditional workrooms, you have medical assistants in one area, resident workroom in another area. And the idea of co-location is to actually be sitting next to the person that you're actually interfacing most with during that clinic. And so having stations where the resident and the medical assistant are actually sitting next to each other, there's much less running around and looking for the person you're supposed to be working with. And then in resident clinics, the other idea is also where do you put the attendings and the faculty members. And so we visited one clinic that had an amazing co-located workroom, and then the precepting room was around the corner down the hall somewhere in this whole separate area. And of course, the residents spent all their time in that room waiting for precepting, and they actually did not get to partake at all in the co-location. So thinking about space and how that works, and not necessarily having to tear down clinic walls for this, because functionally you can build the space to do this without having to, by just being creative. And we have other examples I can talk about. So the last piece of team-based care I'll mention is the idea of shared care. And so that's talking about moving away from this physician-centered paradigm to a shared care philosophy. where all team members are really contributing to and feeling ownership of the health of the patient panel. There's this culture shift towards empowering staff and team members rather than delegation. And this is what allows us to have expanded team roles. And so the example I use of this, so this picture is from Crozier. You can't really see it right here, but it's about, it's a education flip chart that one of the medical assistants at the Crozier Family Medicine program actually created. And so their program, their medical assistants have a huge role in healthcare maintenance and doing proactive colorectal cancer screenings, for example. And to really emphasize this, they do sessions with the medical assistants called like lunch and learns, where they provide lunch and they have the medical assistants all kind of come and get teaching, basically, on why these healthcare maintenance things are important, what it really means to do these things. And so one of the medical assistants felt so inspired by that, she actually created this patient flip chart to talk to patients about the importance of colorectal cancer screening. And so that piece there just is comparing the number of people who die from colorectal cancer to like what would fill a stadium, a local stadium there. And so this is just, again, the idea of like not talking about delegation and just giving people, ordering more things for other people to do, but really empowering your team members, both for patient care and then also as teachers for the residents as well.
Quick question, if I can ask.
Yes.
Is there any programs that have given the MAs, nurses, faculty positions?
There is so Cambridge is like starting to look at something like that. I forget what the term they actually use, but it is something sort of like kind of like a type of like nursing, for their nursing staff to have a faculty type of role. They've actually started looking at that, which is really exciting. And again, thinking about sort of going into the interdisciplinary mode of thinking about things as opposed to this physician-centric model that the academic setting is very prone to towards. Yeah, great question. So Crozier Keystone Family Medicine Residency, which is where that chart was from, they have a teamlet where they have one resident, one medical assistant, and one medical student working together. And that's their example of their co-located workstation where they're sitting right next to each other. And the residents are usually working with one of the two MAs on their color team. They huddle for half an hour before every clinic to go through the list, and the medical assistants have been trained to scrub the charts, as they call it, and to be prepared saying this patient's going to need their diabetic foot exam, this one's going to need their flu vaccine, and then during huddle, the resident and the MA are deciding together which of these things can we do beforehand versus after, or we think this patient's going to take a long time, so for that patient, why don't you go ahead and do these, and really making a game plan for the clinic, and making a huge difference in terms of both the resident understanding what it takes to make it successfully through a clinic, and then also optimizing the flow for the clinic as well. And so the last section I'll speak about, I kind of put these last two clinic first concepts together under the quality of the clinic experience. And so we talk about engaging residents as co-leaders of transformation. And so that means going beyond just kind of talking about, in theory, the ideas of a patient-centered medical home and kind of in theory what quality improvement is supposed to be, and having actually residents have meaningful hands-on experience in these areas, and then empowering residents as leaders in the clinic. So again, not as just, you're just going to be here for 3 years and then you'll be gone and not really have a lasting impact, but we actually want you to be leaders in this clinic and make a difference on your teams. And so the other piece of that, the idea of creating an operationally excellent practice. So basically what we mean by this is getting those 1 through 10 building blocks actually in a really solid foundation and continuing to build on that. But the importance of this towards clinic first is really recognizing that training leaders in primary care requires them to have some experience with a high-functioning clinic. And so I think with a lot of change fatigue and sort of burnout, a lot of what we hear in traditional residency clinics is that it's never going to get better. This is just how teaching clinics are. And so what was very inspiring from visiting all these bright spot practices is that we saw that's actually not true. A lot of places have come up with very innovative ways to engage their residents and provide these high quality experiences. And that well-functioning clinics lead to really positive experiences for the residents, and that they learn that that's actually a doable career. And so an example we have from Crozier, so they use a mantra that the clinic is the curriculum. And so that their residents are learning about practice transformation through hands-on experience. So their residents are really hands-on in the whole process of their clinic's patient-centered medical home redesign. So they were there every work group meeting. They had representatives talking about how should we redesign the workstations, how should we have the teamlets arranged. For residents that are especially interested in primary care transformation, they have kind of like a class rep who accompanies sort of the clinic leadership to some of like the local leadership meetings and for example, their statewide quality improvement initiatives. And they also have this idea of a teaching resident where one of the third-year residents is stationed in clinic, but they're not at their patients, they're there to kind of function as a junior faculty or junior attending in a way, and they're there to really kind of like help precept and support the R1s and R2s who are coming through and do teaching and manage flow and kind of deal with urgent phone calls that come through. And so really learning what that attending role is like. So another example from Erie Family Health Center, and so they pair their didactics with hands-on skills-based clinic improvement work. So for example, residents learn what a PDSA is, and then they actually go into the clinic and do one with their team members. They have a lot of collaborative team education, so again, about the idea of how do you bring in our team members with their expertise to actually also be trainers for the residents. So for example, the nurses teach residents about spirometry, the medical assistants are really the ones that teach the residents how to manage their clinic flow, and their MAs and RNs are encouraged to give those residents feedback. So they're asked for feedback twice a year, so they're just as important as faculty attending feedback in the clinic. They do clinic M&M case conferences, and so with the staff members included, and so as opposed to being in the hospital where a lot of it is about sort of like pathophysiology and things like that, in the outpatient setting, a lot of this has to do with perhaps social determinants of health and some of care coordination gaps, and so they learn about their cases in that way as well. And then their residents go with their clinic leaders to national and local policy meetings, testify at legislative hearings. We've seen in another practice where they kind of get training on how to write legislation brief and have actually passed some local measures. So definitely thinking outside the box about how to engage your residents as leaders. And so I'll kind of sum up with kind of a couple more quotes about what it's like for residents that are working in these high-functioning clinics. And so one resident said, the systems level thinking, the primary care transformation, the QI activity, these really trickle down to the day-to-day on-the-ground clinic experience. So they really feel it. They really feel that we're not just talking about this, we're actually doing it. One of the residents at Crozier said, it's hard to find a place to work like this clinic. I feel like I've kind of been spoiled. Which also brought up the idea from their residency director of like, are we preparing all these residents to work in high-performing clinics that are going out there and then not being able to find similar practices to work in, and kind of thinking, or kind of likening it to like having a product that the market is not ready for. And so since then, he's actually come around to think of it in a different way, which is that, some of the residents are kind of calling back years later saying, I've taken this position at this clinic and they want me to, for example, redesign our teams and like have our team workflows work better. And I did that as a resident, and so I know that exists. And can I get some of those workflows and things like that? And so they're actually really going out there and spreading the models that they trained in, which would be really, really difficult and impossible to do if you had zero experience with that. And then lastly, I think for a pretty good summative quote is from what an internal medicine resident is, this is what I would want to do for patients in my practice. So what I'm learning and training in, this is how I think primary care should be and how I want to do this for patients in the future. So another residency program director said, so good education for tomorrow's workforce requires excellent care for today's patients. So another sort of general guiding principle that we think really underlies what Clinic First is about. So this is our team. I'm just going to wrap up with a couple of resources that I can point you towards. So our website, we've published both some reports that kind of detail these case highlights that I've mentioned, as well as some resource toolkits. So for empanelment, access, and continuity, with specific eye toward residency clinics, we have published some PDF publicly available things on our website. This is the building blocks of primary care assessment. So this is a self-assessment tool that we've created that have been very helpful in terms of practices just wanting to sit down and kind of just see where they're at. And so this is a really great tool that we use with practices for that. We have a training that's coming up in February, and so there's more information on that on our website specifically for your residency clinics. And I can talk more about any of those things, but so I wanted to open it up for questions. I have 7 minutes, I think.
You're good.
It's a lot of information. Yes.
I don't know if it's true or not, but thinking about where residents end up working, in most FQHCs, there's a fair number of nurse practitioners and PAs, and physician starts, and you're expected to provide supervision for them. I remember when I first started, I was I didn't know what MPs or PAs did, and I had no idea where to begin with supervising them. Is there any place in residency where there's any training on that, or?
Yeah, and so the idea of interdisciplinary education and training is really a growing one, and there's a lot of movement around that right now. I think in terms of what is existing out there, or what we know about, is pretty sporadic. So a couple of bright spots I would say is, for example, not for NPs and PAs specifically, but for at Crozier, how they set it up is that they actually also have social work and psychology students, so postdoc students that are psychology based in the clinic and are working with alongside patients. And there are places that are doing that with pharmacy students, for example, or PT students, which is really exciting to see. And just coincidentally for myself, at my program, we did have our site also hosted nurse practitioner students. And so as a third-year resident, we had the option to research and work with the nurse practitioner students who technically was set to graduate at the same time as us. But after working with them, you actually see sort of how different our training streams are. And so thinking about kind of like going earlier into the training process and how can you bring learners into the setting and leverage that. So that's another piece about the team-based care is a lot of clinics ask us, well, we don't have, easy access to, all the different disciplines that we can just hire at the drop of a hat. Really looking at sort of what training institutions are nearby and can be partnered with to bring your students into it can be actually a really good way to beef up the team if you don't already have a super robust, for example, behavioral health or any of the other types of interdisciplinary services you want. Yeah, great question.
One of the ways we tried to do it in my previous role was to have NPs be able to supervise residents with some different rotations. But we got a lot of pushback saying that it was not allowed by ACG rules, and is that still?
That specific rule, I don't know off the top of my head. I know that's like kind of whenever you get into trying to talk about like innovative team-based care, so at some point, there's probably a risk management person who's like, you can't do that for various reasons as well. I would say the best thing to do is actually to challenge it a little bit and actually, figure out, well, where is it that says that we can't do that? Because sometimes when you do delve a little bit deeper, like kind of you're alluding to, sometimes it's just kind of what is inherited assumptions about what you can and can't do. And when you actually look at the fine print, which happens when we're working with practices that are trying to, for example, let their MAs do immunizations under standing orders, but are being told that, oh, well, union rules say this, and scope of practice rules say this, and then actually kind of going and not asking the risk management person necessarily first, because their blanket answer will probably be why we're off the boat, but really looking at where is a rule under like professional guidelines and where is a rule that actually says this. And it's a little bit of a patience testing process, but you actually don't always, it's actually sometimes surprising what you can do with a standing order or some sort of policy, local written policy that you otherwise can't.
Also, David, I might add to that, I have not looked at the ACGB rates from the perspective of any changes in that area. So since there have been so many changes in the last few months, that's one of the issues I would go back and scan through the regs to see if it's addressed.
It comes up because in the practices like ours, we have a lot of NPs, as much as possible. More cost effective, they would care, and I think they do have valuable things to teach residents. And then they kind of learn how to work with.
Yeah, definitely. Yeah. So the question of what exactly is the rule and what does the rule actually say? Because it may say, technically it says this, but oh, we have this workaround that would make this doable. So it's always this. I think it's true throughout trying to improve team-based care that you run up against situations like that. Other questions?
This one goes back to the super nerdy scheduling technology, just because this, I'm sure every one of us has this headache. What's being used out there to schedule people with technology? I remember Excel spreadsheets that I'm way back at this, like my wife, she has 2 days, so it's like, I wish they were.
Yeah.
Now there's all sorts of great technology out there that integrates the system. What's being used? Did you come across any good?
Yeah, so the folks that we have to use all sorts of different things. And I think it's kind of like thinking about what you put into it and what comes out really depends on kind of the originating end. So for example, the Kaiser Seattle site that's doing this kind of really interesting longitudinal integrated curriculum, which sounds crazy when you think about it because of a scheduling perspective, but it actually they was able to put a method to it and make it work. And they kind of blended it to kind of it's like quilting, but instead of quilting with like 4-week squares, like big squares, you're quilting with much smaller, like 3 to 4 day squares. So he is an Excel person, the person who does the schedule, and he's built an Excel tracker to kind of have that all come out. So it's a lot of it is not. I don't think there's one magical like program that has like fix it, just kind of like the HRs, right? One HR that has fixed all the problems, but the people who are kind of savvy about it have kind of really customized or built their own things to make it work for them. Yeah.
So at our current system, we instituted open access and rolling it out to the whole system. Did you see that at all in your clinics, that open access was part of the solution? Or?
Yeah, so one of our clinics we visited, Banner, Arizona, so they do open access in the sense that they only schedule 2 weeks out. And so that was a change that they underwent, with their residents, and it was a culture shock, more so for the patients and for the clinicians as well, because it was like a false sense of security that they felt like was being removed from them. So I mean, it does fix certain things available in certain access metrics. They rotated work for them with a lot of patient education, and really the idea that building some trust with their patient population, that when we say you can call whenever and get an appointment, that will actually happen. But yeah, they do that with their residents who are practicing in that environment, and they're doing it and it works for them.
Unfortunately, we are at time.
I'll stick around for a bit too, so. But thank you all.